Hello, and welcome everyone to this webinar on critical results reporting and interpretive comments brought to you by the IFCC and specifically the Task Force for Young Scientists. I'm Dr. Sean Campbell from the United States of America. I'll be your moderator for today. Just some very quick notes. If you have a question for any of the speakers at any time, please go ahead and put that into the attendee questions box, and I will see them. We'll having all three talks first, and then I'll pose your questions to the panel at the end. We have three really excellent talks, and I want to make sure that they all get their time, so we're going to jump right in. Our first talk is on navigating the maze, effective management and communication of critical lab results by Dr. Sibtain Ahmed. Dr. Ahmed holds a Bachelor of Medicine, Bachelor of Surgery degree, and completed his specialization in chemical pathology with a fellowship of College of Physicians and Surgeons from Aga Khan University. Currently, Dr. Ahmed serves as an assistant professor in chemical pathology at Aga Khan University, where he is also a member of the Departmental Quality Management Committee. He's also a full member of the IFCC Committee on Internet and Digital Communications and chair of the Pakistan Society of Chemical Pathologists Communications Committee. He has a special interest in laboratory quality management, and he is a U.S. NAHQ certified professional in healthcare quality. Dr. Ahmed, please take it away.
Thank you, Dr. Sean. My slides are visible, hopefully. Okay. Thank you, Dr. Sean. Thank you, IFCC, and thank you, Dr. Sean, and the entire committee for giving me a chance to speak on this prestigious platform today. I'll be talking about the navigating the maze. After my presentation ends, you will be actually able to figure out why I called it navigating the maze. And I'll be talking about the effective management and communication of critical lab results. So I have nothing to declare. I would just like to thank the organizing committee, thanks to the IFCC, and thanks to the participants for attending this session. My talk today will revolve around what actually are critical cal values and the reporting requirements, establishing and optimizing these values, and our role in communication and effective management of these values and the entire process. Close your eyes and imagine someone you care for is in the hospital, awaiting critical lab results. The doctor suspects a diabetic ketoacidosis, and for this patient and his family, every minute counts. You anxiously wait, knowing that the timely results could mean the difference between life and outcomes. So that's life. And people always look forward to happy outcomes. This was a patient of a 45 years old male non-diabetic with nausea, vomiting, and abdominal pain. And his timely, effective communication of lab results showed markedly high glucose values of 600 mg per dl, positive ketones. Based on the lab results, effective and prompt management was initiated. The end results are happy outcomes for the caregivers, for the families, and eventually for the patients. So we actually are the lab professionals. We are actually the heart of this entire process. And we would like to help the families and the patients as much as possible. Coming back to my topic today, what actually are lab critical values or critical results? They are at times termed as panic values, but the term usually carries a suggestion of emotional stress and runs against the thoughtful and organized process of communicating important information clearly. Its use is therefore discouraged, and the value should be appropriately named as critical lab results. So, from the definition perspective, these are the values which reflect pathophysiological derangements at such variance with normal as to be life-threatening if optimal management is not instituted promptly. Also, these results indicate a life-threatening situation for the patient because of their critical nature. A timely, urgent notification is appropriate by the healthcare professional is necessary. So, how are these regulated? Critical care values are regulated. If you look at the requirement from the accreditation agencies, they are everywhere. From CLIA, it requires a written procedure for critical value results reporting. From the JCIEA, the Joint Commission, it requires documentation and readback, and you need to define these values and critical tests in your vocabularies of the test. And from the College of American perspective, pathologist perspective, they require a phase two requirement is that you have established policies and procedures, documentation, you have a readback and effective communication algorithm in place, and you record these and you document these, and you manage the effective timelines that you have written in your policy manuals, in the quality management systems. So basically, the labs are required by all these regulatory agencies to develop and put into practice the critical value policies. Although the content of these policies may vary according to institutional needs, the core components are often quite similar across the board. So, how should clinical labs establish critical value lists and determine appropriate thresholds? So, given the complexity of individual systems and practices, I know that it's very difficult, and the regulatory agencies also allow us an autonomy when it comes to defining our critical value list. Many labs often do a consultation with their ordering or requesting physician practice groups. The value in this approach is that a critical value list developed with a medical practice community is one of the clinical's perspective. However, they should be very inclusive, uh, or they should not be very exclusive. I would follow both the terms. Why? Because if they are too much inclusive, or that the value that thresholds that require excessive notification, and they will place an unnecessary burden on the lab staff. While on the other end, if they are very much exclusive, or with thresholds that are too high or low, that might not prevent adverse clinical outcomes, as a delay in the recognition of life-threatening results by clinicians can be disastrous. So you need to manage adequate balance between values that are exactly appropriate, that can help you and that can help the physician in order to make prompt clinical decisions. So, how should clinical laboratories establish these values? The best practice to start with is establishing or modifying critical care value lists by comparison with previously published literature. You need to look up. There are literature already available on the in the books, in the World Wide Webs, and on in your various guidelines. And you need to then evaluate the practice parameters, consensus document, because these sources have been refined already with the benefit of time, institutional comparisons, and clinical performances. So you do not have to reinvent the wheel, but you need certain modification depending upon your lab or your institutional or hospital's need in consultation with your physician, as I mentioned in my last slide. Also, there is an important point is the inherent variability in assay-specific reference values or reference intervals between institutions. That could be a complicating factor. So you need to have something very much catered to your own needs. That is, an individual laboratory director is also the one who is accountable for this variability by defining critical ranges consistent with his or her own assays and instrumentation. This task may include meetings again with the relevant ordering requesting physicians, your medical and surgeon section chief, the hospital administration, and nurse managers to discuss your critical care values policies and to determine if there are any tests that should be included or omitted, and whether any threshold should be adjusted according to their specific clinical needs. So basically, this is it's a combined effort. You need to have all your stakeholders on board when you develop a checklist of critical care values that you must be using, because clinicians need lab input and we need clinician support in order to make the processes work. So it's always better to shake hands and always better to have a comprehensive liaison that will eventually enhance patient care and safety. So, who should make and receive critical values notification? According to the JCIA and the CAP, the laboratory procedures must indicate by whom and to whom critical results are reported, as well as the acceptable length of time between the availability and reporting of critical results. According to CAP, it specifies that information must be documented during critical value notification, including the necessary elements are date, time, responsible laboratory individual, and the person who is notified. Because if this is not documented, remember, if it is not documented, it is not done. Several hospitals have implemented the use of automated notification systems for critical values reporting, like text messages, paging systems, electronic communications. But patient privacy requirements should also be considered with automated solutions, because data conceivably might be transmitted and stored on non encrypted devices as well. The rationale stated in the National Patient Safety Goals states that results are to be conveyed to the responsible licensed caregivers, the ones who have the direct engagement with the patient and who are dealing with the case should be appropriately and timely informed. The CAP checklist again describes notification to a physician or other care critical professional responsible for patient care and the appropriate clinical individual. CLIA refers to the individual or entity requesting the test and, if applicable, the individual responsible for using the test results. If you look at all these statements, one thing is common, that is appropriate clinical individual responsible for the direct care of the patient should be appropriately and timely notified in order to make the clinical decision necessary based on the lab values, the critical care ones, in order to ensure optimal management and high standards of patient safety. Coming back to the CAP standards, when critical results are communicated verbally or by phone, there should be a policy that the lab personnel ask for a verification readback, because at some times the results can be misheard, can be miscommunicated, and they could lead to sentinel disastrous events. And the lab personnel should document the readback. Transmission of critical care results by electronic means is also acceptable according to the accreditation agencies. However, if they are transmitted electronically, the lab should confirm the receipt of the result by the intended recipient. However, no readback is often necessary in the cases of electronic, but there should be a readback receipt. Records of critical results notification with documented readback should be kept and maintained by the laboratory, and these are part of the CAP inspection and CAP audit processes. What should a lab do when a technologist is not able to reach a responsible clinician with the critical value? This often happens. Then the answer is an escalation policy. Now, what is an escalation policy? It is a policy that directs the lab technologist to contact a supervisor, a pathology physician, a resident, or a medical director to assist in critical care value notification. This policy actually helps the technologist to refocus on the important task of lab testing, and it transfers the responsibility for notification to people who may have greater access to an inpatient or outpatient medical record and who can put the findings in a broader clinical context. So your job is not done if you could not find the right individual. If you cannot trace them, you need to follow your escalation policy, and you need some sort of communication to be established in order the results to be informed. And some sort of information that I am saying should be placed in your policies in the form of an algorithm for your inpatient as well as outpatient settings. So after trying to contact the ordering provider, the algorithms includes attempting to identify and contact the patient's primary care provider. So your job is not done until you have not informed. And as all labs do, you need to follow your appropriate algorithms, and you need to have your checklists in place, and you need to document each and every stage in order to ensure your safety as well as in order to prove happy outcomes for the patient that was in the slide number 2. So, how might critical value reporting be improved? Approximately 70% of surveyed labs have a policy on repeat critical care values. For those that do not, one is strongly recommended because it will clarify lab technology responsibility and establish consistency. So, labs should consider the value of repeating the test versus having the results available faster at times for the clinical team to take action. So, this often remains a dilemma to repeat or recheck the critical care values or inform straight away if you are pretty much sure of your systems and processes. So, Shima and colleagues at Kaiser Foundation Hospital in San Francisco retired their policy of repeating critical results, and they were able to improve the lab's efficiency and TATs. And a 6-month monitoring period showed no reportable patient care issues because of implementing the change. So you need to reevaluate your practices. If you are doing a lot of rechecks, you will save time. You'll improve your TATs, and you will also have some cost benefits. And it has been proven to be effective in global leading practices, one of the developed countries of the world. So how will you monitor that you are working fine and you are following your policies and you are appropriately informing? Now it's the time for some key performance indicators. So this should be followed by that. The mean time to call may not be helpful for setting targets and reporting data. So you really want to know is how many you meet and how many you miss and how many did not meet the target. So in that case, you need to have an appropriate KPIs for this critical values, timely reporting and communication in place, because that will be part of your next performance improvement project as well if you don't have right now. So you can start with clinical audits. So clinical audits can be then in the sort of an analysis of critical care value limits that can be used to estimate the impact on call frequency, that would result from changing threshold requirements. You can also reveal differences in critical care values by patient locations. Example, falling hematocrit values on surgical services versus low potassium on medical services. This information could be used, for example, in the evaluation of a new point of care system that might be targeting get in place. Others have used critical care value analysis in studies of adverse events as well, and clinical activity at discrete hospital locations. So this is time for some improvement. If you already have a mechanism in place, go and audit it. Go and see how can you improve. Go and see how can is there any gap that you need to fill in, and is there any room for improvement. And I always believe nothing is 100%, and there remains some sort of missing links that it is our duty to fulfill, and that can only be achieved if we regularly do inspections and audits of our practices and try our level best to improve them. So, what are the responsibilities of lab directors, medical directors, pathologists, and in the critical care value process? So, this is where the main part of my presentation's title comes into play. So, you need to train your staff. You need to do the critical care value audits. You need to ensure compliance with the accreditation agencies. You need to implement your critical care values alongside the appropriate interpretative comments that my colleague will be following up in the next presentation. Then you need to have the appropriate information, communication, and escalation policies in place. And you also need to face the clinicians at times when you lag behind. And this actually requires a lot of effort from the team. So I would again call a lot of effort from the team, because this is not an individual effort. Because to clear this maze, and you need to have a consolidated effort from your team members that are involved in the entire testing process, and your teams that are in operation and the frontline warriors in the lab. So to ensure that critical care values are appropriately documented, informed, and you can help with the interpretation of to your physician colleagues. Our recent CAP today Q&A discussion on critical care values shows some interesting lines that I would like to quote. A focus on building a patient-centric system requires strong pathologist leadership to ensure a safe and reliable system. So your teams work under brilliant leaders, and you need to have an appropriately individual spearheading your entire process to enable a win for you. So your duty is to build a reliable team and communication system with the goal to make them as reliable and robust as possible. These systems can improve critical value reporting processes by automating and streamlining notification, learning from past mistakes, audits, standardization, and setting meaningful targets as your KPIs will have covered have you help you cover your weaknesses, and you will have a win-win situation for the patients, for your physicians, and for the labs as well. Now, I would like to thank my colleagues from my labs who ensure that the critical care values are reported timely for our appropriate patient care, for our inpatient and outpatient settings. In fact, I would like to thank all lab professionals globally who are, the heart of this entire system. Because without their help, and without their assistance, the patient care is suboptimal, remains suboptimal. And my final slide, I would like to thank the IFCC office. Just like critical care values, these ladies help us to keep us informed that the critical webinars are taking place daily to improve our clinical knowledge and to have refresh ourselves. Thank you.
All right. Thank you very much, Dr. Ahmed. That was an excellent presentation. I appreciate it. Okay. As mentioned, any questions, please put them in the attendee questions. I see we already have a few, so that's excellent. We're going to be answering them at the end. So for now, we're going to move along to a presentation on the use of interpretive comments in modern laboratory medicine by Dr. Ashlyn Rempel. Dr. Rempel is a specialist chemical pathologist at Pathcare in South Africa. He is also a core member of the IFCC Task Force for Young Scientists, and he was the former chairperson of the African Federation for Clinical Chemistry Young Scientists, and he has had many prestigious positions, including the College of Medicine Young Specialist Committee Chairperson. He has presented and organized many international and local conferences where he has helped develop young scientists, and he continues to mentor and aid young scientists, residents, technologists, and clinicians today. And he is the first pathologist in Africa to win the Mentorship Award for Excellence in Africa. And he wants young scientists to be the best that they can. So Dr. Rempel, please take it away.
Thank you, Sean, for that brilliant introduction. And thank you, Dr. Subtain, for that brilliant presentation. And the key word from Dr. Subtain's presentation is that teamwork is important. I'd like to thank all the young scientists attending our webinars and participating in our activities. I'd also like to thank all the laboratory professionals that are attending this webinar. It's a very crucial topic which is presented. And the second topic that I'm going to talk about is interpretive comments in modern laboratory medicine and what we are looking for in the future as young scientists, and how do we implement in the digital era interpretive comments. So we know that interpretation of laboratory tests is a complex post-analytical process that harnesses critical knowledge by pathologists and lab personnel. The ultimate goal for us as laboratory personnel is to ensure the appropriate interpretation and utilization of laboratory information for an effective decision-making process that guides to best patient management. Now, this slide is very important because I am going to talk about interpretive comments, but I want to also talk about interpretive comments and how the digital era is taking us forward in laboratory medicine and how it can improve interpretive comments. So the digital era, we use big data in the lab. Artificial intelligence is a very important topic, and a lot of young scientists are involved in artificial intelligence and programming. The use of evidence-based laboratory medicine is important. The patient that needs to know because of the information era. We have patients that are Googling and using newer technologies that want to know about their health, and interpretive comments in preventative medicine rather than disease. So this is a crucial focus that I'm going to talk about and give some examples at the end of the presentation. Right? So why the need for interpretive comments? First of all, it's important in patient safety. There's a value of comments, both to the clinician, to the patient, and it's important. It's a quality requirement. It's an ISO 15189 that it's important that interpretive comments are used in many laboratory data. It gives physician satisfaction as well as the patient satisfaction. Again, the need for interpretive comments, the introduction of new and complex tests. We have lack of harmonization of these new and complex tests. Therefore, interpretation is needed by the clinician and the patient. It's important in medical education, electronic communication, competition between different labs. It decreases the healthcare burden in terms of costs, and most importantly, it prevents medical error, right? So this is a basic diagram taken from the articles on interpretive comments, and it's important to evaluate your test results. That's procedure 1, decision to release the results, test results, procedure 2, and then preparation of the laboratory test report, which is procedure 3. So there's various procedures involved in this complicated process, and it makes it less complicated when you have a system in place. And then you follow in procedure 4 in terms of electronic release of laboratory test report in terms of, as Dr. Subtain said, phone out or electronic communication. And then importantly, moving to procedure 5, reporting of the test orally, talking about the critical limits or unexpected results, and obviously interpreting those results, giving a comprehensive interpretive report where necessary for certain of the results. And then following procedure 6, 7, and 8, where we need to the storage of sample is important, archiving, and then the post-analytical quality indicators. So if we guided by these particular documents, we need to have these particular documents according to the ISO in place, where administrative data is captured, like for example, the name of the patient, where they live, what they're here for, the date and time of sampling, patient identification information, as I said, name, gender, date of birth. The attributes of the measurand are important. What type of sample, reference intervals according to age, gender where applicable. Results should be in SI units where applicable. Confirmation of data, and finally the comments, which is important as it helps the clinician and the patient and laboratory personnel. So the current demand for interpretive comments and its desirability spring from clinical, technical, and financial catalysts. Now, evidence has accumulated to demonstrate the risk of errors due to misinterpretation of diagnostic tests in different clinical settings. For example, your primary care, your emergency departments, and internal medicine departments, and their impact on patient safety. The inclusion of interpretive comments in laboratory reports could decrease error rates, thus improving the quality of laboratory information and patient safety. Right? As I said, it's an ISO recommendation for laboratory directors to provide clinical advice in the interpretation of examination results, including the inclusion of interpretive comments on results, and where applicable, the addition of interpretive comments has been recommended in several clinical guidelines to improve the utilization of laboratory data. Okay. As I've stated, new and complex tests are merged by many scientists and many laboratories, and it represents a major driver for the inclusion of interpretive comments in the laboratory report. This is particularly true in some diagnostic areas and harder diagnostic areas such as coagulation, autoimmunity, allergy testing, and molecular diagnostics that present a major challenge due to the need of advanced expertise for the correct interpretation of laboratory data. In addition, interpretive comments are increasingly welcome by requesting physicians, but particularly when they provide clinical advice on what to do next. And it saves on healthcare costs, as these clinicians, if the test is interpreted properly, a comment is given, they don't request the same and duplicate tests. Rather, they follow the protocol of what do I do next with this particular result. Again, we talked about the lack of harmonization of laboratory information, not only in analytical methodology, but also in measurement units, reference intervals, and decision limits is a further driver for the inclusion of interpretive comments. Current evidence from papers highlights that medical education on laboratory testing is inadequate, and junior doctors do not feel confident in interpreting even common laboratory tests, at least in part because many medical schools have moved towards newer ways of undergraduate teaching, which have reduced the time available for teaching the pathology disciplines. So we found in our private sector as well and public sector that junior doctors feel confident when they have interpretive comments in their reports. Okay, so again, the need, increasing competition between clinical laboratories that is predominantly based on costs could better be addressed if other variables that provide evidence of quality of laboratory services are considered. The availability of interpretive comments could represent added value to requesting physicians and users, and it's proven. The need to reduce cost of healthcare, specifically costs related to laboratory testing, should shift the focus from volume reduction to the reduction of inappropriate requests and, even more important, inappropriate utilization of laboratory information. Current evidence highlights the huge percentage of laboratory results that are poorly acknowledged and misinterpreted, leading to missed or delayed diagnosis and treatments. Hence, the need for interpretive comments. Physician satisfaction of interpretive service is backed by evidence. Contributing factors include a significant reduction of errors and improvement of clinical outcomes. So all in all, this, by working as a team, it's a complete brain-to-brain loop. You need to have a certain level of understanding between your physicians, your patients, your laboratorians. This interpretive comments guides the whole system and makes it in synchrony. And that is very, very important. So hence, we've proven the need for interpretive comments. But what we as young scientists and laboratory personnel should do with interpretive comments for the future. I'm talking about where do we take it? We know there are basic interpretive comments for tests. For example, a urine metanephrine that is 3 times the upper limit of normal proves the fact that there's a pheochromocytoma. That we know, it's there, it's backed up. But how do we take interpretive comments to the future? Interpretive comments in our generation as young scientists. So what about the 21st century? It is the digital age. Where do we go with interpretive comments now? The information technology era. And this is where young scientists need to get involved with the digital technologies, big data, AI, evidence-based laboratory medicine. This will help them in furthering science. So big data. We know we have an LIS system in our laboratories. Majority of our laboratories are equipped with LIS system, which holds data. You can analyze data from 300,000 specimens, 90,000 specimens, and you can prove via science that a certain phenomenon is observed. For example, we know that in certain climates, especially the winter periods, we get the concept of pseudohyperkalemia because of the sodium-potassium pump. And this now can be an interpretive comment proving the facts with big data. Say with many studies, these are just reference articles using big data and proving a phenomenon using science and using these as future interpretive comments. Now, I enjoyed a very brilliant talk by one of our young scientists, Dr. Ashish Agrawat. And this is where we can use AI and interpretive comments. Now, Dr. Agrawat is a member of the CPR committee. I urge you to join him, and maybe he must give this talk to the young scientists who are interested. We also have a digital competence group that is led by Jacob Adler. That's nice to join because these are bringing artificial intelligence, machine learning, and digital technologies into the forefront of laboratory medicine. So thank you, Dr. Ashish, just by quoting his slides. Now, remember I said the interpretive comments are in the post-analytical phase of the lab. So AI also contributes to the post-analytical phase by automating result interpretation and reporting processes. This reduces turnaround times and enhances the reliability of laboratory reports, which are critical for timely and accurate clinical decision making. Now look at AI. AI is taking laboratory medicine forward with regards to it. Because if you look at it here, what Dr. Agarwat has put together with his presentations, we normally perform LDL cholesterol with estimation based on HDL cholesterol, total cholesterol, and triglycerides. Now, what Dr. Agarwat is saying and what these research reports are showing and these papers are showing that using AI programming like Python, etc., it can perform better than the Friedewald and Martin equations, which are used in interpretive comments. So now, as young scientists, we are moving one step forward and using AI for interpretive comments. And there are many examples quoted here. Prediction of chronic myeloid leukemia, the prediction of Down syndrome in the second trimester using AI and using that data that is obtained from your lab and obtained from maybe collaborative effects from many labs. Okay, their papers are being produced on AI, and this is where we want young scientists involved in all of this. Predicting cardiovascular disease, interpretation again. So there's many to predict SARS-CoV-2 infection using machine learning. So all of this is taking us to the digital era where we're proving that AI can be very, very important. Okay. Now let's look at evidence-based laboratory medicine. From my lab in PetCare, I do many hundreds of parathyroidectomies. A parathyroidectomy is removal of a parathyroid gland due to an adenoma commonly. Now, uniquely, I've come across a typical case, which is case 1. We can see that before the parathyroid gland is removed, the basal PTH will be raised. It is 40 in this case. Okay. After removal of the parathyroid glands that having the adenomas, you would expect the 5-minute and 10-minute PTH to drop, and it does drop ideally in a proper scientific way by 50% the 5 minutes and by another 50% in the 10 minutes. Right? But we don't always see this, hence the need for evidence-based laboratory medicine. Look at case 2. You have a basal PTH of 18, but a 5-minute post-parathyroidectomy of 38 and a 10 minutes, which is lowering to with normal levels. And when we go to theater and we engage with the surgeons and you would see the case, each case merit by merit, we find that in this particular case, the 5-minute high is due to the surgeon gland handling and difficult procedure. So him squeezing the parathyroid's difficult location it gives a spike in the 5-minute parathyroid gland. Look at case number 3. You have a basal PTH typically high before the gland is removed. The 5-minute is still remaining high, but the 10-minute now is high. And when we check the case, the evidence is there with the surgeon that 5-minute is high due to gland handling, and the 10-minute is high due to continuous blood supply to the gland. So the blood supply was not removed to the gland, so it was still secreting parathyroid hormone, hence that comment. And these comments, doing it case by case with the physician or the surgeon, it shows and demonstrates evidence that comments can be helpful to the clinician, which is the surgeon doing the procedure, but also to the person that is monitoring the patient after, when they do a parathyroidectomy, parathyroid hormone the next day and a calcium, they know that this procedure was due, the values due to this procedure were high because of this incident during the operation. Now, the last part of the talk is preventative medicine and comments of the future. And this is where it is important. We as laboratory personnel diagnose disease, but we diagnose disease late. So we say that this person had a myocardial infarction, we treat it. But what about preventative medicine? How can we prevent something using our laboratory data? And this is important. Let's give you 2 different troponin I results here. We have a patient 1 with a troponin I of 367 and a patient 2 with a troponin I of 12. Clearly, we know patient 1 with a troponin I has a myocardial infarction, it is high. But what would patient 2? Normal laboratorians won't use the data and they'll say, well, this patient didn't have an MI, it was a routine checkup, it's 12, it's fine, send the patient home. But that 12, the patient to 12 becomes significant in the future, and I tell you why. Now, there's something called troponin I which is used in cardiovascular risk stratification. And there are many studies that are quoted here that show how we can use risk stratification to help the patient prevent future disease with the Hunt study, Woskop study, Jupiter study. We can see that at certain troponin levels that there's a hazard risk according to the parameters of the patient. So the patient has risk factors, there's a hazard risk that is high, and we say screen this patient and modify their diet, properly give this patient a statin. It can help them from having a future MI in the future. So you want to have preventative medicine. And it's proven that the patient given a statin had actually decreased their troponin I levels over time. And that's where cardiac risk stratification comes into place, where we're talking about gender specific, where we say you're at a low risk if you're a male and your troponin I is less than 6, and you're a female if your troponin I is less than 4. Moderate risk, greater than 6, less than 12 in a male. In a female, greater than 4, less than 10. But if you're at elevated risk, a troponin of greater than 12 and in a female greater than 10, then we look at other parameters, look at the cholesterol levels, thyroid function, where is this patient going in the future, and we can prevent cardiovascular disease. So guys, I hope that this presentation intrigued you to understand that we want to take interpretive comments to the future using big data, using AI, using evidence-based laboratory medicine, and trying to have preventative medicine in laboratory medicine rather than just diagnosing disease. With that, I'd like to thank you so much for listening, and particularly these particular people I'd like to thank. So thank you very much, Sean and the YS, for listening.
Excellent, Dr. Rampo. Thank you very much. All right, and again, moving right along, we have quite a few questions, so that'll be great for the end. So next, we have a presentation on the reporting of critical risk laboratory values, and specifically the experience of a worldwide survey by Dr. Judith Gonda. Dr. Gonda worked from 2016 to 2024 as a clinical laboratory pharmacist at the North Pest Central Hospital Military Hospital in Budapest, Hungary. She now lives in Zurich, Switzerland, and her main areas of interest are quality assurance in the clinical laboratory, clinical chemistry broadly, mainly cardiac biomarkers and tumor markers, and she is a young scientist and organized a project on conducting a survey on the reporting of critical laboratory values at the end of 2023, and that work is what she'll be telling us about today. So Dr. Gonda, please go ahead.
Yeah. Thank you, Sean. So can you all see my slides then?
Yes, it looks good.
Awesome. Yeah, thank you. So good afternoon, everyone. And first of all, I would like to thank to the IFCC and to the Task Force Young Scientists for this presentation opportunity in this webinar. I would like you to imagine this scenario. A patient is rushed into the emergency room with severe chest pain. The attending physician orders urgent tests, and within minutes, the lab identifies critically high potassium levels, a result that signals imminent cardiac arrest if not treated immediately. The laboratory flags this as a critical result, and information is swiftly communicated to the medical team, saving the patient's life. Now, consider the opposite scenario. What if the result had been delayed, miscommunicated, or not acted upon? The outcome could have been tragic, and this is the stark reality we face when we're dealing with critical risk laboratory results. I would like to introduce my co-authors in this global survey project, Maria Schröder-Castaño, Kamil Taha-Uchar, and Mari Lansky. We presented our project as a poster presentation on in the World Lab Dubai this year. Let's begin with a foundational understanding of critical risk laboratory results. These results are life-threatening results that need immediate medical attention and action. There are national recommendations as well as institutional protocols for reporting the critical risk results, permitting the structurization and optimization of the total testing process in the clinical decision-making. In the next 20 minutes, I will guide you through the aim of our global survey, the methods and the key findings we found, including the trends and the challenges identified, and also the weaknesses and opportunities for improvement. By the end of this presentation, I hope you will leave with some actionable insights that you can bring back to your own laboratories. Critical risk laboratory results often referred to as panic values or alert values, and they can determine life or death decisions. Yet, the processes surrounding their identification, reporting, and response vary widely across laboratories and healthcare systems worldwide. We aim to better understand the routine reporting practice in different countries with three main objectives: to compare the protocols between countries, to describe how critical values are defined and how they are reported to clinicians, and to conclude the added value of laboratory medicine in the total testing process of the emergency analysis. The effective management of critical risk values is a complex task. Laboratories face challenges such as variation in protocols and communication gaps. Variation in protocols meaning that the different institutions and countries adopt different thresholds and processes for critical values. The communication gaps mean that ensuring that results are delivered promptly to the right clinician can be sometimes difficult, particularly in complex healthcare settings. And then now with this background in mind, let's turn to the methods and the results of the survey. So a global web survey containing 40 questions was conducted by young scientists, so the four of us, during the November months of 2023. We extended our surveys in the African countries for 1 month in the summer of 2024. And we did this because we did not have enough data to be representative from the African countries. Our project was supported by the IFCC Task Force Young Scientists, and it was disseminated by the IFCC in 4 languages: English, French, Spanish, and Turkish. We focused on laboratories performing emergency laboratory tests such as biochemistry, hematology, coagulation, microbiology, and toxicology. We received responses from 236 laboratory professionals from 63 countries and from every continent of the world. Almost half of the responders work in laboratories with less than 1,000 samples per day, and 1/3 of the responders work in laboratories dealing with samples between 1,000 and 5,000 per day. The participant represented a variety of laboratory settings, including academic, hospital-based, and private laboratories. And more than 3/4 of the responded work either at a public hospital or at a university clinic's laboratory. Now, let's continue with the results. I will divide the results section into 4 different points. The first, developing the alert risks and thresholds. Second, defining critical risk values. 3, awareness. And 4, reporting process. So let's begin with the developing alert risks and thresholds and the applied guidelines. Around 80% of the respondents reported that the laboratory used locally developed procedure to report the critical risk results, while 42% of the respondents used national guidelines. The ISO guideline is used in 52% of the labs, and the CLSI, the respective CLSI guidelines, is used in 16% of the labs. And the responding laboratories not exclusively use one guideline or procedures. That's why the different percentages. This table summarizes the most common critical values in the different fields. Most of the labs had defined values in biochemistry and hematology and coagulation, mainly the iron levels, the glucose level, the kidney function test, the hemoglobin, and the platelet count. Almost half of the laboratories have critical risk value in the field of microbiology, mainly for the cerebrospinal fluid findings. And also 1/3 of the laboratories have a critical risk result in the field of toxicology, and mainly for the psychotropic medications. Now let's move on to the sources of critical values. Laboratories define their critical values using one or more approaches. More than half of the labs used some literature source, or they consulted with the clinician in their institution. And around 1/3 of them used the respective ISO guideline or a manufacturer test description, and 12% of the respondents used the respective CLSI guideline. Regarding the collaboration with the clinicians, 1/4 of the labs did not involve the clinician in defining the laboratory value list or the alert procedure, or both. How the lab get aware of a critical risk result? Around 40% of the labs use flags, which is either a color code or an exclamation mark, and it is appeared either on the software of the instrument that measured the sample or in the LIS, the laboratory information system. 63% of the labs always give notification of a critical risk value, even if the value is recurrent, while 31% only give a notification if it occurred for the first time. 64% record the unsuccessful notifications as well. More than 70% of the labs record the test and the result that was reported, the name of the person who reported the result and also who received the report, the result, and also the time and date of the report. How these notifications are getting or are logged in the laboratories. They are mainly, so 2/3 of the respondents use the laboratory information system to log the notifications. 1/3 of the labs log the notifications manually on a separate sheet in the lab, and surprisingly, 11% of the labs do not record the fact that they reported a critical risk result. As for the reporting process and the communication timeliness, 70% or a bit more than 70% of the labs reported that critical risk results are communicated within 30 minutes after the measurement. And the report is mostly done by the lab specialist during the day and by the lab technicians during the night. A so-called call center suggested by the CLSI only reports in 10% of the laboratories. And who receives these reports? Mainly the clinician who ordered the laboratory test, and also in a great amount of cases, the nurse from the department where the patient is admitted to. As for the preferred communication method, phone calls remain the primary method for reporting the critical risk result, used by 88% of the respondents. However, other technologies like as a short message or an LIS message are gaining traction with 21 and 32%. As for the contact details, half of the laboratories reported that they have their own collection of contacts, such as a telephone directory, either in their lab or in the institution. 1/3 of the labs reported that the contact details are available on the test request form, and also 1/3 of the labs reported that the contact details are saved in the laboratory information system. These findings paint a complex picture of how critical risk results are managed worldwide. While there are clear strengths, such as the rapid communication in many settings, the survey also exposes vulnerabilities that must be addressed. In the next section, I will discuss the weaknesses and the opportunities for improvement. So 65% of the labs use no readback, meaning they don't verify that the verbal report was recorded accurately by the recipient. This is very important because 88% of the reports are done by the phone. 44% of the labs reported that they don't have an escalation protocol for delayed communication when the responsible caregiver cannot be reached on time. And also 44% reported that they don't have a protocol for identifying responsible caregivers if the patient is already discharged or for outpatients after office hours. As for the application of quality management, it seems from the responses that the critical value list is not regularly reviewed and updated, only if there is if there was a complaint or an unpredicted case. The assessment of turnaround time and the reporting, the critical risk reporting as quality indicators for laboratory quality and performance review purposes is only available in half of the responding laboratories. However, there were also some good tips and good practices that we read during the evaluation of our survey, and I would like to share these with you. For example, there is one lab where a report is generated every 4 hours by the LIS to capture the missed critical results. There was also another lab where the recurring or the most often dialed phone numbers are available on the notice board. So it hangs on the wall of the laboratory, and it makes the reporting time shorter. As for the reporting methods, there were some alternatives for the methods, such as writing a WhatsApp message or using a pager, or in small laboratories or small hospitals, there may be possible to do the reporting personally. The management of critical risk laboratory result is a vital aspect of patient safety and healthcare delivery. Our data show the heterogeneous practice on reporting critical risk laboratory values around the globe. The most participants follow national guidelines or local institutional protocols based on the respective ISO and the CLSI guidelines. The laboratory medicine professionals do their utmost in collaboration with clinicians to contribute their work and expertise to the emergency clinical decision process. However, a global harmonization of critical risk result reporting and cross-country sharing of practical tips could be beneficial. And I would like to say a big thank you to all the participants taking our survey, and you have really made a lasting impact. And as we bring this discussion to a close, I want to leave you with a final thought. The work you do as laboratory professional has a profound impact on patients' life. Each critical risk results that you manage represent not just a number, but a person who may be depending on you for timely, accurate, and effective action. Let today serve as a reminder of our collective responsibility and our capacity to drive improvements to save lives. These steps can be, for example, refining our processes, embracing new technologies, or advocating for global standards. I would also like to recommend an event for you that is more like a celebration. The IFCC Public Relations Committee, in collaboration with the Task Force Young Scientists, organizes the Global MedLab Week each year. And the aim of this event is to unite the global medical laboratory community in celebrating and promoting the indispensable role of laboratory professionals in healthcare. The topic for last year and also remains for next year is the Lab Saves Life. And it's an opportunity to raise awareness of the pivotal role of laboratory diagnostics. You can contribute by organizing activities such as academic activities, social activities, or cultural activities, or you can also share materials such as podcasts, videos, or photos, or other creative content with IFCC. All the submissions should align with the topic Labs Save Life, and they may show the impactful stories and experiences. You can save the date, so it's going to be next April 2025, and you can also check out the globalmedlabweek.org webpage, or you can also see the Global MedLab Week in Instagram account and Facebook account, and see the content from the last years. So all in all, thank you for your attention and your webinar participation and your dedication to advancing laboratory medicine. I look forward to your thoughts, questions, and the opportunities we have to learn from each other. Thank you.
Fantastic, Dr. Ganda. Thank you so much. Okay, we have now come to the end of the formal presentation period. Dr. Rampal and Dr. Ganda and Dr. Ahmed, feel free, please, to turn on your cameras. So I have a great list of questions here. Feel free, again, if you have additional questions, please continue to send them in. We'll take a look, but I'll start by posing some questions. I'll also pose this to a particular member, but if anyone else on the panel would like to answer, please feel free to jump in as well afterwards. Okay, I'll start right in with a question for Dr. Ahmed. There was one from Faryad Ali, and he was wondering if there's any particular benchmark that you would use or suggest for setting a result value as a critical result, what you use.
Okay. So as I already told during my presentation that you need to dig in, you need to do some homework, you need to prepare a checklist, you can check already published literature. You do not have to reinvent the wheel because there are a lot of resources already there available. You can refer to textbooks, you can refer to published articles, and you can also use previously published critical care values list that you have available, but you need to modify according to your needs. And the best approach that I already emphasized upon was to get in touch with your clinician colleagues who are your direct caregivers and who are your direct test requesters. And if they do agree with the benchmarks that you have set for or a particular threshold that you have set for the critical care value for that particular analyte, that could be your assay or instrument specific, and then you can set it as your targets that you need, that you'll be following. And there's always room for improvement if over the course of your practice you see that there's a particular benchmark that is too much inclusive, that you are doing a lot of critical informing that is doing extra burden on you, or that is too much exclusive that you are missing. You can always modify according to your needs in liaison with your clinical colleagues.
That's great. I agree. Excellent answer. Okay, I'll jump forward to a question for Dr. Rempel. This is one that I personally wonder about. So along with artificial intelligence, there's also questions as far as things like hallucinations and incorrect answers. So can we be sure that artificial intelligence interpretations can be dependable?
Look, you have to. It can be dependable. Like the example I quoted, Sean, on LDL cholesterol, we're using the what we call this the other equations, the Martin equation and the Friedewald equation. We found that artificial intelligence, if you read that paper, and Dr. Ashish would tell you that artificial intelligence, it's better. That the data is proving to be better, and then the LDL is of a correct value. So it's not a hallucination. I mean, with the things like Python, R programming, it's proving to be taking laboratory medicine forward. So I don't think one should say hallucination. It's just that we need to get used to the technology. I think as young scientists, we need to go for these training platforms, R programming, Python, and we need to be more involved in the digital era. Otherwise, we're going to lose focus. It's needed in laboratory medicine. That's my take-home message on that. Thanks.
Very good. Thank you. One for you, Dr. Gonda. Since you've been collecting all of this information, do you either personally or scientifically have a feeling about what method is better as far as recording results to clinicians of the ones that you mentioned?
You mean during the survey? Can you repeat that, please?
So there's a lot of different methods that people use to record alerts, right? The question is, do you have a feeling about which one is most successful?
Yeah. I think the most successful could be recording it in the LIS. So the paper method is not that good, I think, because if we record it electronically, then you can search it back. Yeah.
Yeah, that makes a lot of sense. Yeah. Another one for you, Dr. Ahmed. This is kind of along similar lines. Do you feel that there is a benefit to, or is it better to send values directly to a patient, or should they go to a lab or a clinical person before it goes to the patient? So, your microphone is muted. Sorry.
Oops. Okay, so I would again refer to the College of American Pathologists standards in order to give some weightage to my answer to this question. But the CAP requires us that the information should be trickled down to the appropriate clinical care provider. That is, the physician is the most appropriate person in case of patients who will be eventually making on clinical decisions based on the values that we have communicated. And at times, these care providers can be the nurses who are present working at the bedside. They can be the resident physicians, but they should be because the nurses and the resident physicians are working under the direct supervision of consultant physician for that particular patient, and they ensure that the results are timely communicated to the physician who is in turn responsible for the decision making. So I strongly believe and I strongly advocate, and that is also supported by the CAP standards, that the clinical caregivers are the most appropriate personnel to be informed regarding a critical care values and not the patient himself or herself directly.
May I just add on to Dr. Subtain? Dr. Sean, can I just add on to that statement? I agree completely with Dr. Subtain, 100% following the CAP guidelines, ISOs, etc. But there is some gray areas on that question. For example, we had in our experience that a patient had a troponin of like 800. So obviously that patient was having an MI. We couldn't get hold of the GP. The GP tested the troponin I. And what we did was we couldn't get hold of the GP. So that now is a critical result. So what we did is we saw where the patient was staying, because it's important to have the patient data. And you don't want to phone the patient as well, because the patient will get anxious and something can happen. You'll be responsible. But it's a gray area, because if you leave that without the GP getting the result, the patient can die. So what we did is we phoned the nearest casualty to the patient's house, and the casualty officer sent an ambulance to the patient's home. So you get gray areas where, as laboratory professionals, remember we are healthcare professionals, where we can't just sit and do nothing for those circumstances. So thanks. Yeah.
I would also like to add to this patient thing, some thought. So based on our survey, the patients are reported in 17% of the cases. So it really happens. Yeah.
Yeah, I agree, and I've had similar situations as well where we can't get in touch with someone with a critical result. So yeah, I think to add on to that, right, there should be a hierarchy. I absolutely agree that the clinical personnel are the ones that should be getting these results, but you do have to make those decisions when it gets to a problematic area. All right, let's see. Dr. Rempel, another question for you. Again, similar line. So when it comes to interpretation of laboratory results, do you have suggestions there as far as who should be responsible for those interpretations, right? Is it laboratory technologists? Is it faculty? Is it something else?
I think it's a team effort. I think you need to form a team, as Dr. Subtain was saying. All should be involved. Technologists, pathologists, technicians. You should have a discussion, and then you put the interpretation forward, because everyone should understand the interpretation before they give. Because remember, the physician sometimes will call a lab, they'll speak to a technologist. So I think it must be a team effort. Bring a team together to bring and bring in those interpretive comments, especially if you're going into newer interpretive comments and newer assays, etc. Then you need to always have a committee in your lab to QAD department, quality assurance department, that's headed by a pathologist, technicians, technologists, all involved. The other thing I want to say, Sean, in terms of patients, I think the patients, as I'm saying, they're getting very intelligent in the digital age. So I think having webinars and seminars and taking laboratory medicine to the patient is also important. So opening these webinars for patients, for people that are reading, so they get educated. I don't know how laboratory professionals feel, Dr. Subtain, Dr. Judith, but I think we're going also in that direction, where patients need to understand what they're testing. And sometimes they are self-referral patients who want to check their cholesterol. So maybe that'll aid them to know this total cholesterol means this LDL, HDL, all the other abnormalities. I don't know what Dr. Subtain and Dr. Judith feel, and yourself, Dr. Sean, as you're a laboratory professional yourself. But that's my view.
Dr. Gonda, Dr. Ahmed, if you have anything
So,
to add there.
it's okay. So, I strongly support Ashlyn's point of view, because we need to have some sort of, educational activities for the layman persons as well. Number one, it will help us to enhance the vision of lab medicine, and people will understand how we actually are the unsung heroes who are working in the background, and how we are in, included in the patient care part as well. And I strongly believe that we, as the lab professionals, are the custodians of the lab reports and their interpretative comments, and we can develop a better, interpretative comment, and that can be understandable easily and comprehensively by the caregiver, not only the caregivers, clinical caregivers, but also by the patients. The report should be comprehensive enough that the patient should get at least some information regarding his or her clinical state based on the numbers that we report. So we should advocate for patient education, because it's high need of time. Because if we do not do it, they will themselves do it, and that could lead to false information and false interpretation. So we need to perform our duty very well in that domain as well.
Yeah, I totally agree, because of when sorry. So when we give real information to the patient, then that's when they can get information about, yeah. Sorry. Yeah.
I agree, and actually we continue this for a second because we got a question that was kind of similar, in that patients have access to these results, these interpretive comments, these critical results. So yeah, there is a question as to what can we give to help inform the patient. I know that I have similar issues. I sign out reports, then those can occasionally go to patients, and I have gotten feedback from clinicians sometimes if they would like me to reformulate a comment because they know a patient's going to see it. So yeah, absolutely, it's important for us to keep in mind how we are able to educate the patients as well as our clinicians. 100%. Anything additional on that, if anyone wants to jump in?
I would add some other we did not examine that in our survey, but it could also be important, the problem of understaffed the understaffed and the overburdened laboratories, that they may struggle to meet the demands of rapid reporting. Do you maybe have any experience on this in your laboratory or?
Yeah, I'll open it up to everyone. I will say
Yeah.
we have been we have similar issues, I'm sure, and we have been working on other systems like electronic reporting, as opposed we typically use phone calls, but those two take more time, and we have been experimenting with just electronic communication to pagers or messaging to help with that overhead. That has been successful somewhat. Dr. Rempel or Dr. Ahmed, if you if you've run into this at all. Okay. Okay. Sorry, I look like Dr. Rempel froze for a minute. That's fine. Okay. Another question for you, Dr. Gonda. I'm wondering if you have any insight in this. So we've talked a lot about kind of more typical laboratory tests, but there's also point of care testing, right? That the individual generating the results is also the one there. Is there anything you've seen as far as critical reporting around those results?
Yeah, we haven't examined that in our survey, but that's a good point. I think the POCT test, because they usually are not done in laboratory settings. They are usually done, for example, at a GP's office, or maybe in some countries in a pharmacy or something like that. And it should be, or should there should be a guideline on that. I don't know whether there is any guideline on critical risk reporting with the POCT test. But yeah, it's a very important topic, and we didn't examine that in our survey.
There. I will. Yeah, I was just about to throw it to you, Dr. Ahmed, if you have any insight.
Okay, thank you, Sean. I would just like to add one thing to what Dr. Judith added. The beauty of POCT test is that they are performed near the point of care, at the bedside, at the pharmacy, and you get the results instantly at the site of patient care. So adequate clinical decision making is taken timely on the spot. So the one thing that is the main duty of critical care results informing, I believe, is solved in real time because of the help of these POCT tests. So you do not have to go back and follow the same algorithm just like the lab test, because it is right there and in the hand of the physician, in front of the patient, the instruments most of the cases, and you get real time results, and you get to take real time actions.
I think, Dr. Sean, that was a good point from Dr. Ahmad, because it is there at the bedside, and the clinician is getting the result immediately. But coming to that point of care testing, I think it's an avenue to explore. I was just talking to Dr. Subtain earlier, Sean, and I think maybe we can do a global survey on point of care, because point of care is going forward. So maybe he can head that task, and we can go with the collaborative countries. But interesting question, interesting.
So watch this space. Maybe we'll have something more. All right. Another question for you, Dr. Ahmed. When you're looking at, especially how to, like you were saying, audit these sort of results and look at how successful they are, there's kind of the amount of time it takes as well. Are there other metrics that you use to really measure the success of these?
Yeah. So actually, you need to have appropriate key performance indicators in place. First of all, you need to decide that what are your targets, what are your benchmarks for these key performance indicators. One you have already mentioned, the right time in front. You can also add the number of tests that are part of your critical care checklist. You can always improve the critical care test checklist of your number of tests. Then you can follow that you can also keep an audit of the documentation process. Basically, that it is the documentation process that is missing at times. The physician's office comes back to us that this patient results was critical, but it was not informed timely. And when we go back and look at the results, it is not documented by the lab staff that he or she had documented it. So one thing that is very important from inspection or audit perspective is the documentation. I would again emphasize, because if you have done it, but even if you have done it and not documented it, it will not count. So it's our duty to document as well. Documentation at times lags, that needs to be audited. The read back mechanism lags, sometimes it needs to be audited. The critical results informing times are the main factor, as you have already mentioned, that they need to be audited. And if you are meeting benchmarks, if your KPIs are coming on 100%, then you need to be increased. Then there is a gap. Then you need to increase your benchmark. If you are informing 95% of the results, maybe next time your benchmark should be 98, and then you can eventually build on. So it's not about increasing the KPIs. It's actually about meeting the targets. Even if you have only two KPIs and you are meeting your targets, and you are eventually increasing your benchmark for those KPIs, and then you can actually enhance your performance. And in cases when all your KPIs 100%, I again, in that case, I believe that there is again a need to go back and check, is it really 100%, or is there something exorbitant that you are doing at the back end. So you need to keep on auditing, and audit cycle is important. You just cannot leave the process after one audit that it is good. You need to repeat the cycle, and you need to do a continuous monitoring of the entire process in order to ensure the optimal performance.
Absolutely. Excellent. Thank you. Another one for you, Dr. Rempel. You're a big proponent of AI, is clearly, but some people are concerned, right? So I have a question of, with AI being used for interpretation of results, are you worried it would replace laboratory professionals in the future?
Never. Doctor, I also asked Dr. Subtain, is point of care testing going to replace us, and now AI going to replace us? No, they will always be. Remember, you are the one controlling the data. You are the one you as a pathologist, the technologist, you're still going to run your tests. You're still going to perform your duty as a pathologist. You're going to analyze that data. So there will always be not point of care testing, not AI is going to remove the pathologist and the laboratory staff, for that matter. I think, Dr. Subtain, I have asked you this question, so maybe you can answer that as well, just to put
Right.
people at ease.
I will just speak two sentences. AI is there to help us, not to replace us. And my next sentence is, machine will need man behind them.
Very fair.
Absolutely.
All right, the next question, we'll start with you, Dr. Ghanab. I think, Dr. Ahmed, you'll also have important things to say. So one of the methods that you mentioned was alert through WhatsApp. How do you see that fitting in, especially with, you mentioned the importance of being documented in the LIS? Is that a valid method of report communication?
Yeah, I don't think so. It's a valid method, and I also think it's a bit personal. So you may have the phone numbers of the clinician or the nurse, and you can send a WhatsApp message to raise the awareness of a critical risk value. But I don't think that's so, how to say that, it's a bit confidential. I think texting on WhatsApp. So I think when we need a better documentation, it should be done either in an email, so in a formular way, or by phone then, or through the LIS, which is I think would be the best. Yeah.
Okay, can I ask you something, Dr. Judith? If
Yeah.
the clinician does not respond to you on WhatsApp, okay, but he reads the message, what does that say? He read the message, was blue ticked. What does that mean?
In my opinion, that it means that he got the message. Maybe he didn't have any time. Yeah, but I think that's a proof. And maybe on WhatsApp you can also click on it and see when they read it. So you could document that, but I don't think it would be the best for the quality assurance. Yeah.
I agree with that as well.
Yeah.
Speaking of that, Dr. Ahmed, do you know of a requirement to document the clinical values that we inform the clinicians, that kind of documentation of readback? Is that a requirement, or something that you suggest?
Okay, so even I think if even if the lab is not following any accreditation agency's particular requirement, there are many labs worldwide who are not accredited by certain regulatory bodies. But again, I would suggest that following good laboratory practices, whether it is your local requirement or not, you need to document the critical results, communication, and management in your SOPs. How will you follow? You need to have algorithms in place that are easily doable for your technical staff, and you need to document their progress, and you need to have something that you can go back and audit. So I'm a strong advocate of documentation, and even if your lab is not following any particular agency's accreditation requirements, it is our duty as lab professionals to have these in place.
Yeah, absolutely agree. Dr. Rempel, I got two very similar ones for you. Do you know of any restrictions or regulations, ISO or otherwise, around the writing of interpretive comments by pathologists or scientists? Anything to guide those?
Interpretive comments. Well, it must be guided by scientific data. So the more publications on that particular topic, when science is brought forward, for example, a pheochromocytoma, we know 3 times the upper limit of normal proves it's a pheochromocytoma. So you put it from science and evidence and guidelines. From that, that's my view on it. I don't know, Dr. Subtani, is there any other guidelines? Because I know we look it from literature and from
Yes,
data.
you're absolutely correct. You need you
Yeah.
you you basically look up it from your literature, and basically, according to the accreditation bodies, it is the responsibility of the lab director or the personnel who is supervising the entire operation to ensure that the interpretative comments are appropriate, and they are and the main thing is that there should be an appropriate reference. That, for example, when the reference interval, for example, when the interpretative comments are challenged in a court of law, or any query arises from the physician, you need to have a document from where this interpretative comment is taken, and that reference has to be legitimate. And as a laboratory director, it is your responsibility to evaluate that scientific reference, and when you feel that the reference is appropriate, it is from a legitimate body, and it is accepted globally, and then you can only put forward in your report
Yeah.
as an interpretative comment.
Yeah, absolutely makes sense. I have two I kind of want to pose to all of you, because I think this is ones that we can all weigh in on. And the first one is, this question mentions emergency departments in specific, but I think this is a general, especially if you're using phone communication. How do you deal with departments that just do not pick up the phone repeatedly?
Okay, from our experience, if your lab has a courier or a CLO, it's good to take it directly to that particular emergency department, hard copy, and give it to the nurse that's taking in charge of the patient, or the physician. If you don't get hold of the physician, the nurse, tell the nurse this is it. You need to phone the doctor, and then document that on your LIS system if you're failing to get hold. So there are simple communicative strategies. Sending your courier or your CLO, which is your client liaison officer, or a laboratory technologist who's just out for lunch, especially if it's a critical result, or is on a lunch break, or somebody of your lab personnel, documenting that they handed this over, signed in a book, and then you use that as evidence that you gave this to a healthcare professional. So that's one example. I don't know, Dr. Gonda, Dr. Abad, what else you all guys do?
So for me, this is where the escalation policy comes into play. As Ashley already mentioned, you need to use all your resources. I know it is very difficult. I know it's very a tedious task, but this is our duty, and this is our core that we need to lead from our end.
Yeah, according to our survey, also the escalation protocol is what they should use. Yeah, it takes time. Yeah, but it's what it should be used. But what Dr. Rampo suggested, a hard copy or a personal reporting could be also a good choice. Yeah.
Yeah, agreed. I will also say in our hospital we have documentation system for we call near misses or laboratory harm, and we could also use that. So yeah, if someone's not responding, we can put in that we tried and this was a potential danger to the patient, and that will get to the department as well. So I would suggest that too if you have it. Okay, another kind of general question for this, and again we have a few along the similar lines, and that's around kind of alert fatigue, right? So we have there's an idea that if you're calling too often or if you have too many pop-ups in your LIS, that physicians are going to start ignoring you, kind of in a similar way. Do you have any suggestions for either how to track that, how to oppose it, how to make it so that we are being properly paid attention to? And I think this also, just to bring in, goes to the questions around of repeated alerts, right? So if you have, for instance, we have patients with blastocysts, you have to call them and let them know there's a potential cancer. If you get 4 CBCs, are you telling them every time, or what is your kind of idea around that to help contain that?
Right.
I think in this situation, lab professionals should consult with the clinicians, and each department at the hospital should have their own critical values, in my opinion. For example, for nephrology, a high potassium level or a high ureal level. It makes sense in those patients, and you wouldn't phone to the nephrology department. So in my opinion, then every department should have their own list of the critical risk result, and the lab professional should consult with the clinicians, and also the clinician should so in the other way around, so the clinician should have open ears to the lab professionals.
Right.
My view is this, Sean. Also, what we do is that we communicate to the physician or the clinician who's in charge of the patient, and we specifically tell them. They tell us no, they don't want to be called on this. You document that this doctor does not want to be called. Make him sign a declaration that he won't be called for that particular result, and then it's on the system, and then it'll be not phoned as per doctor's instructions. That's one, right? Number two, then typically, like when a patient is undergoing dialysis, you'll expect the pre-dialysis, the urea, creatinine, as Dr. Gonda is saying, will be high. The potassium will be on a higher level as normal. When they're undergoing dialysis, the sister is called. So there are certain protocols, but we can't let go of critical first-time patient results. Troponin I, potassium, a very high sodium, a baby that was brought to the hospital, those have to be communicated. But we can, as you said, if too many pop-ups are coming up, the doctor is getting tired, you go to him, you say, doctor, what do you want? What is your instructions to us? And he says, no, call me only when the bilirubin is 360. Anything 300 to 310 or to 350, you don't call me. Call me above 360. So you have that instruction there, and that you are not responsible as a healthcare professional. If something happens to the patient, the doctor signed the declaration, the clinician signed the declaration, your lab, and we as healthcare professionals must not be sued. So we need to document everything. So the word is document. Yeah.
All right. Let's see. I think we're gonna close things up. I did have one follow-up actually in the questions, which I wanted to bring up because it's important for a previous note. So Dr. Rempo mentioned with AI that Python and R we can get involved. I will say, as someone who's not as good with coding, that could be a little scary. So one of our attendees did mention that there are various tools that do not require any coding at all. So if that's a thing holding you up, I agree with Dr. Rempel. This is something that we need to get involved with. So don't let that scare you. There are other options available.
No, Dr. Sean, absolutely, because there's that Dr. Agarwal will tell you there's an orange program, some orange way you just put in data and that thing will help you with the coding process. So you're absolutely right. So those that are not, they thinking they are not computer literate or coding literate, there are other options available. But if you are younger, and especially younger lab professionals should get involved, you know how to use the computer, you're using all these devices, it's quick to learn, I'm sure. Well, I didn't do it myself, but I will try, and I will say it's quick to learn.
All right. And with that, I wanted to thank you, everyone who attended this webinar, especially those that added in questions. And of course, thank you very much to Dr. Ahmed, Dr. Rampal, and Dr. Ganda for those excellent presentations that provided such valuable information for everyone. And of course, thank you to the IFCC for offering this e-learning tool. Now, we did get to quite a few questions. And again, thank you to the whole panel for answering them. But there were still a few that we didn't quite get to in time. So those we will reply over email to those of you that posed those. Certificate of participation will also be provided at the end of the webinar after a few questions, just to show that you were here for the whole thing. At the end of the questions, please click show my scores at the end of the page, and that will get you your certificate. And last, on-demand content of this webinar will be available shortly, and you'll be informed via email as well about that. There will soon be other IFCC free webinars, and they will be announced via IFCC communication channels on email, the website, and IFCC social media as well. So please look forward to those. All right. Thank you, everyone, again, and have a good day.
And thank you for being a great chair, Sean. Thank you so much for chairing the session. Thanks.
Yeah.
Thank you.